Perfect. It looks like everyone's connected well. So I'm going to start. Good morning, everyone, and thank you for joining us today. My name is Kate Toomey, and I am the Sexual and Reproductive Health Project Officer at the Centre for Excellence in Rural Sexual Health, also known as SERSH. I'd like to welcome you all to providing HIV care in 2026, which is part of SERSH's Sexual Wellness Professional Development Series. Today's session is presented by Dr. Darren Russell, whom I will introduce very shortly. Now, before we begin, I'd like to acknowledge the traditional owners of the lands and waterways across Victoria and Australia, which we are all joining from today. I'm joining from Dja Dja Wurrung country, and I'd like to pay my respects to elders past, present, and emerging, and I'd like to extend that respect to any Aboriginal and Torres Strait Islander people online with us today. I also want to acknowledge the deep importance of Indigenous knowledge in the field of sexual and reproductive health. Wherever we are zooming in from today, we are all on Aboriginal land, and it is important to note that sovereignty has never been ceded. Now, quickly, just a few housekeeping notes for today's session. We kindly ask everyone to stay on mute during the presentation, but please feel free to share your questions in the chat, as I will be actively monitoring it throughout. This session is also being recorded, so if you prefer not to appear on screen, please switch off your cameras now. This PD will be available on the SERSH website next week, so you're more than welcome to revisit it whenever you like or share it with your colleagues. Now, it is my absolute pleasure to introduce you all to Dr. Darren Russell. Dr. Darren is a sexual health physician who works at Kardinia Health, Geelong University Hospital, and Prism Health. Darren also holds the position of Adjunct Professor in the College of Medicine and Dentistry at James Cook University in Cairns and is also Professor at Deakin University. He is a past president of the Australasian chapter of Sexual Health Medicine of the Royal Australasian College of Physicians, the Victorian AIDS Council, and the Australian Federation of AIDS Organisations. Darren was also the Principal Investigator for the Queensland HIV Prevention Study QPrEPd. His interests include Indigenous sexual health, transgender health, and the elimination of hepatitis C infection and HIV transmission in Australia. Thank you so much, Darren, for presenting this morning, and over to you.
Great. Thanks, Kate. That's a lovely introduction. And I'd also just like to pay my respects to the elders and current people of the lands we're all meeting on today. I'm on the lands of the Wadawurrung people near Drysdale in Geelong. So yes, you might have heard that I had an association with James Cook Uni in Cairns, and I was up there for 20 years, but I've returned home to Victoria to the I won't say the better weather down here, but anyway, to the better coffee in Victoria and Melbourne. I'll try and share my slides now and see how we go. Share that. See if we can. All right. How's that, Kate?
It is showing as your speaker view.
Right. So what we need to do is to swap.
Perfect.
Got it. Okay. Thank you. Whew, pretty good. Before we started, we were talking about Zoom and how many of us around the country had been using it a lot before COVID hit, but we're still having problems with it several years on. But I'll start talking about HIV treatment and prevention in Australia. I'll talk for a while, and if you do have questions, I think you can add them into the chat feature there, and Kate will moderate that and interrupt me as appropriate. So if you have any questions, feel free to type them in. I've made this deliberately broad today because I know there's a real mixture there. I saw one familiar name who's a sexual health colleague of mine in Darwin. So I know there's a doctor at least there. There's probably nurses, allied health, might be some academics, might be some students. So I'll try and deliberately keep it broad. But if there's something you don't understand, please ask. We used to have the joke about HIV that it was a condition of people with and affected by acronyms. The field is full of abbreviations and acronyms. So I'll try not to use too many for you. Okay, so what we're going to do today is talk a little bit about the current epidemiology of HIV in Australia, who's got HIV, who's getting HIV, understand some of the contemporary ART principles, there's the first acronym, antiretroviral therapy, or antiretroviral treatment, so treatment with HIV meds, and apply the U equals U, which is undetectable equals untransmissible, PrEP and PEP. PrEP is pre-exposure prophylaxis, so something that people take mostly every day to prevent HIV, and PEP, post-exposure prophylaxis. So you've had some fun, you wake up the next morning and go, oh, damn, shouldn't have done that, and go off and get some medication that you take for the next 28 days. So we'll talk about that. And we'll also try and integrate some of the clinical and public health approaches, so keeping it broad. A snapshot of HIV from last year. There's about 29,000 people living with HIV in Australia, and a lot of people who aren't familiar with HIV are quite surprised at that high number. There's so little about HIV in the news these days, it doesn't figure very much, whereas in the 80s and 90s it was huge news, and even into the early 2000s. But there's about 29,000 people happily, quietly living with their HIV. Of all the people who have HIV in Australia, we believe over 90% have been diagnosed. So it's a fairly small number who are still to be diagnosed. But that 10% or less is a very important number because they are the ones who could be transmitting HIV without being aware of it. Of those who are diagnosed, over 90% are on treatment, which is a great take-up. And of those who are on treatment, over 95% have their viral load suppressed. So the virus is really scarcely detectable in their system. And we'll talk about why that's important later. So Australia is actually doing very well overall, but we've still got a fair way to go. So this just shows it in a slightly different way. The number of people diagnosed with HIV sitting, when we last looked, about 92%. Of those, about 90% are on antiretrovirals, and of those, about 95% virally suppressed. And when you compare this to figures around the world, it's actually pretty good. There's a few countries doing better than us, but overall we are doing very well. There was an aim to virtually eliminate HIV transmissions in Australia by 2025, but that came and went. So the government shifted the goalpost to 2030. So with a bit of luck, we'll get closer by then. Slide. So who mainly has HIV? And of course, nearly all of you would know, in Australia at least, it's predominantly gay and bisexual men. Sometimes that's abbreviated now to GBM. We used to talk about men having sex with men. The abbreviation there was MSM. But more often now we talk about gay and bisexual men, which is really just males in Australia who are having sex with other men. Overseas-born populations, and increasingly we're seeing diagnoses of HIV in people born overseas. And this is in contradistinction to those who are born in Australia, where the new diagnosis of HIV is dropping quite dramatically. Aboriginal and Torres Strait Islander peoples are overrepresented, and we had quite an outbreak from about 2014 to 2017, 2018, largely centred around Cairns, where I was, and numbers of Indigenous Australians with HIV jumped quite dramatically during that time. The overall numbers were small, but the proportions were quite large. The increase was quite large, and that was very worrying. We were quite concerned that the epidemic would get out of control within Indigenous communities, but it doesn't appear to have done that. A couple of decades ago, we saw similar rises in Western Australia, both in Perth and in some more remote areas. And again, that was very worrying, and a lot of public health efforts went in to try and contain that epidemic at that stage. Heterosexual transmission is still important. And I think if you ask the average heterosexual around Australia about HIV, they wouldn't be able to tell you much at all these days, and probably don't think they're at risk. And in a way, they're not at great risk. The proportion or the rate of infection in Australia per 100,000 is really very low for heterosexuals. That doesn't mean people don't acquire it. And one of the problems is if they do acquire it, no one thinks of the diagnosis, so they often present quite late and quite sick. This is the trend for new HIV diagnoses in Australia, and you can see over the last 10 years or so, we've really had a nice downward trend. And this is good. New diagnoses don't necessarily equate to new infections, of course. Someone can be infected and not diagnosed, but we do have pretty good testing in Australia. So this is a reasonable attempt at looking at how many people are actually being infected and then being diagnosed. Of course, someone may have been infected 5 or 10 years ago and only been diagnosed now, and they'll show up. And likewise, people who are very recently infected will show up. We think on average about a third of the new diagnoses are recent infections, so within the last 12 months per the definition. So the new diagnoses are dropping. If I haven't separated it out, but if we looked at people born in Australia, the rate is really dropping much more rapidly. Almost a majority now of the new diagnoses are in people born overseas. And this is quite a change from what we saw in past decades. So how is transmission occurring in Australia? Well, sexual transmission is the predominant cause. So this is vaginal and anal sex. We've known for decades that this is the way of transmitting HIV. HIV is present in semen, in vaginal fluids and cervical fluids, and in rectal mucus. So HIV transmits from men to women, from women to men, from men to men. Women to women, extremely rare. There's been occasional reports, but they really are very rare. Blood exposure, very uncommon. Injecting drug use, of course, is not rare in Australia, but transmission is actually very uncommon in this population. And that's quite different to some other parts of the world, Asia, Latin America, Eastern Europe. Eastern Europe has had very high rates of HIV. And you might have heard more recently about Fiji in the South Pacific, which now has the most explosive HIV epidemic in the world. And I was just reading yesterday that 3.1% of antenatal women are now HIV positive. So over 3 in 100, which is really quite devastating. And the concern is that this could spread throughout the Pacific. And some of that transmission is injecting drug use through stimulants. Fiji is a bit of a hub for transit of stimulant drugs, amphetamine-like drugs. And so blood exposure does occur there through injection. Vertical transmission, so from mother to baby, is really very rare. I haven't looked at the latest figures, but it's almost unheard of now. It's extremely rare in Australia. Every so often one will occur, but very uncommon. We have very good antenatal screening in Australia, so nearly all women are tested for HIV. Certainly in the public system. Private system is pretty good, but there are a few gaps there. So in Australia, overwhelmingly sexual transmission and overwhelmingly anal sex between men, although heterosexual transmission is certainly in there too. How do we test? There are what we'd call indicator condition testing. So if you see someone coming in who's got pneumonia and it's a bit atypical, you're not sure what's going on, you may test. Someone has anemia, a low red blood cell count, you may test. A young person getting shingles, which shows sort of a potential problem with the immune system, you may test. So doctors and nurses, other clinicians around the country may test for HIV based on the clinical presentation of someone coming in. Then there's risk-based testing. Gay men in particular are encouraged to have regular testing, especially, if they're highly sexually active. So those who have had risks are encouraged to test, and their clinicians are encouraged to test them. And this is the same for people coming from overseas, high prevalence countries, guys heading off to Thailand for a holiday, or the Philippines where there's more HIV and possibly contracting HIV there. Same in Bali. I've just seen 2 young men recently contract HIV from a bloke in Bali. So, this is a fairly, or not a rare way to contract HIV today is from a country that has a higher prevalence than Australia. And then routine testing in high prevalence settings. So sexual health clinics, prisons, drug and alcohol settings, etc. Just doing routine testing. And there's routine antenatal screening in Australia. Antenatal testing is really on low prevalence populations, but still very important, because if we don't pick up HIV in that population, the risk of the baby being infected is significant. So they're the three sort of testing strategies that we use in Australia. Test types. So how do we actually test? Predominantly, it's with a blood test take venous blood, you send it off to the lab, you ask for an HIV test or an HIV antibody test, and they're what we call fourth generation antigen antibody tests. So the antigen is the virus itself, usually what's called the P24 antigen, which is a part of the coating of the virus, the surface of the virus. So that the test that we do nowadays in Australia looks both for the virus and our antibody response, the immune system's response to the virus. As such, the testing is extremely accurate, and really certainly within 2 to 3 weeks of being infected, you can find HIV there on routine tests, and sometimes earlier than that. After that test, if that test is reactive in the lab, it goes on for Western blot testing. And this is a much more complicated, sophisticated test that's done only in sentinel laboratories. It's only done in a few laboratories around the country that are recognised as being expert in this, and do the sort of public health work for that particular state or territory. So the Western blot is then done, and that confirms HIV or says it's not HIV after having a positive screening test. Nucleic acid amplification tests, that's what NAT stands for. They look for the RNA or the DNA of the virus. And a viral load test, you might have heard of viral load tests for someone with HIV. That's a type of nucleic acid test. So that is sometimes done, or a DNA test looking for HIV DNA. Now here we get a bit nerdy. HIV is a retrovirus. It's an RNA virus, but it makes DNA from RNA, which is kind of the wrong way around. It's arse about. So that's why it's called a retro or reverse virus. So you can look for that DNA as well. Those tests aren't done commonly when we're trying to diagnose someone with HIV. There's also rapid and point of care tests, and these are usually finger prick tests or saliva tests. You can purchase them online, and particularly sexual health clinics and some emergency departments in the country carry these and will do this test on someone if they think there's a high risk of HIV. Certainly in Cairns, we used to carry them out very regularly. It varies from state to state, clinic to clinic, but they're certainly in Queensland used very commonly. And there's also clinics like Pronto in New South Wales, and there's another one in Brisbane, Rapid, that uses these tests for screening high-risk individuals within the community. So a variety of tests are done. Why does early diagnosis matter? Well, to stop people from getting so sick. Without treatment, HIV is almost 100% fatal. It does take some years generally for that to occur, maybe 5 to 10 or more years for death to occur after contracting HIV. But a lot of damage is done to the immune system, permanent damage, also damage done to the neurological system, dementia and other issues can occur, and nerve damage. So HIV is a nasty virus. It does a lot of harm. So if we can pick up HIV early, it's done minimal harm at that stage. By finding someone with HIV, we can also pop them on treatment and prevent onward transmission. And that's extremely important from a public health perspective, because one person with HIV, if they're quite, let's say, popular and affectionate, can transmit to a lot of other people. So to prevent onward transmission, we diagnose and get people onto treatment as soon as possible. And it also leads to improved engagement in care. So this is very important as well. We've got a whole lot of things we can do for people with HIV to help make their lives better, help improve the quality of their life. So what are the principles of antiretroviral therapy? So this is a treatment for HIV. Well, it's all combination therapy. We never use a single drug alone. Same as for tuberculosis. You need to use multiple drugs together. At least 2 drugs, usually 3 drugs together. It's lifelong treatment, and that can be hard for some people to understand, that we can't cure this infection. And if they stop their treatment, nearly always that virus is going to flare up again and start causing damage. So it is lifelong at this stage. A lot of work's going in to find a cure around the world, but without much clear success at the moment, unfortunately. And there's been a big move towards rapid initiation. And this was controversial a few years ago, but even if possible, on the day of diagnosis, starting treatment. It's not always possible. The person might be too sick for that. You might be waiting on certain results. The person may not be ready for it yet. They've just received this information that's going to change their life. For some, it's like being hit between the eyes with a bit of 4B2. You know, they're really quite devastated at it and not in a position to start taking pills every day. On the other hand, I think increasingly, certainly for gay men who know a bit about HIV or know something about it, if they find they have HIV, they often want to get onto treatment. They know about treatment or they've heard about treatment. They might have had a partner or friend on the treatment, and so they want it as soon as possible because they want to do something. So where possible, we'll start same-day treatment. And there's certainly data from the United States that says that the outcomes are better if you do that, and retention in care at 12 months is superior for those initiated rapidly. If we can't start at same day, certainly in the same week or 2 or the same month, as much as possible, we try and get that person onto treatment. They'll often feel better and won't be able to transmit, and their immune system will be preserved. So modern regimens, there's a few different types of drugs we use, but the mainstay of treatment are so-called integrase inhibitors. And there's a whole lot of different classes of HIV treatments. The first one we had, may not have even heard of, was called AZT, that became available about 1987. And it was quite a toxic drug that caused some problems, gave people about an extra 6 months of life before it wore off, but caused a lot of harm to them in that time. We've come a long way since then. You know, I talk to patients, it's a bit like iPhones. You know, the first iPhone was rather clunky and, you know, it did the job, but it wasn't great. But the most modern edition of the iPhone is certainly a big difference from what the first ones were. The technology is much better, as it is for these antiretrovirals. They're really quite amazing drugs. Very safe, very effective, very few side effects, and seem to be able to be taken forever with very few problems. So we use combinations. We try and use once daily fixed dose. So the most commonly used drugs are one called Biktarvy, which has 3 drugs in the 1 pill. And there's another one called Dovato, which has 2 drugs in the 1 pill. And they're just taken once a day with or without food. And highly effective at dropping the viral load and keeping the person well. As I said, excellent tolerability, virtually no side effects with these drugs. Very high barrier to resistance. It's hard for the virus to escape and to become resistant to these medications. I kind of tell people that they really have to work at it. You know, it's not an easy thing to get resistant to these modern drugs, whereas the old-fashioned drugs, if you missed a few doses, it was quite easy to end up having resistance, and then that class of drugs may not work for you anymore. There are now long-acting injectable agents and a whole lot more in the pipeline. There's a drug called cabotegravir, which is 2 injections, 1 in each buttock, given every 2 months. And so that's used in Australia. There's another one called lenacapavir, which is a 6-monthly subcutaneous injection. It's not used as commonly. Cost is an issue. And the other problem with that is it's only 1 drug, so you still have to combine it with a daily pill. So it's not ideal. You're still taking something daily, even though this 1 drug is 6-monthly. But both the 2 or 3 major drug companies involved in HIV treatment have got several new drugs in the pipeline that could be given every 2 months, 4 months, 6 months, even 12 months. They're looking at delivery systems a bit like Implanon, so the contraceptive that women have as the rod that goes in the upper arm. They're looking at all those kind of things too, so that someone could have one of those inserted every 6 or 12 or 18 months for antiretroviral treatment. So watch this space. A lot of new treatments coming, but the ones we have now are daily pills or 2 monthly injections. And this shows what happens to the HIV viral load. You see how rapidly it drops down. So if the 100% here, or you could say 100,000 copies, but let's say 100%, and really quite rapidly within 4 weeks, you're going to have very, very sharp drops, and the virus is usually undetectable within 1 or 2 months. So quite an amazing drop. And this renders the person much less infectious. As I said earlier, we've suppressed the virus in Australia in about 95% of people on HIV treatments. And basically, if they take their tablet each day or they get their injection every 2 months, they're going to be suppressed. They're not going to have virus that we can find readily, or it's going to be at a very low level. And at that very low level, they don't transmit, and we think we'll have a near normal life expectancy, especially if they've started early after infection. If they've waited till they were very sick, their life expectancy is likely to be shortened. But if they start, within the first year or so of infection, people may well have a near normal life expectancy. And I've said for quite a few years now to my patients, I'd rather have HIV than diabetes, because diabetes is hard work. You've got to watch your diet, and you've got to exercise, you've got to look after your eyes and your kidneys and your feet and all of that. HIV, it's actually much easier. You just take your pill each day. There's not much else you need to do generally. Oops, sorry, typo there. The viral load, that's supposed to be, is the viral load is the primary marker. So we measure the amount of virus in the system, in the blood, in the plasma, and that's called the viral load. And it gives a level of, for example, 50,000 copies of virus per mil. That's kind of an average level. Over 100,000 is quite high. Under 200, 200 is essentially undetectable, and the person cannot transmit the virus then. The CD4 count, the T cell count, is much less important nowadays. It's all about the virus. In the old days, we couldn't measure the amount of virus, so all we had to go on was this CD4 cell count. And the CD4 cell count is one of the white cells, and it's a white cell that helps to protect against HIV, but it's something that HIV attacks. So HIV attacks and destroys these CD4 cells. And the way I describe it to patients is a bit like Pac-Man, if any of you are still old enough to remember Pac-Man, although Pac-Man's probably retro and come back now. But the CD4 cells are trying to munch the HIV virus and kill it. At the same time, HIV is trying to get the T cells and kill them. Over time, HIV wins, and your immune system is damaged. That's a very, very simplistic way of looking at it. We do blood tests every 6 to 12 months, and general health stuff. So blood pressure, weight. We check lipids, we check sugar, and so people with HIV sort of get more regular and thorough healthcare interventions. We make sure they get vaccinated against influenza and COVID and pneumonia and shingles and other things. So there's really very good healthcare, particularly in Australia, for people living with HIV. And their health overall can be somewhat better than those without HIV, because they're getting a lot more preventive healthcare and often looking after their health better. U equals U. Undetectable equals untransmissible. And this has been around, the concept, for, I'm going to say 10 years, but certainly quite a while now. And it's really very, very important. There have been big cohort studies around the world that have shown that if the person's viral load is low, they do not transmit. And in fact, sort of 0 transmissions have been recorded in people with very low HIV levels. This is sexual transmission. So 0 sexual transmissions, and it applies to vaginal and anal sex. Injecting drug use is a bit different. We don't have as much good data in that, but it certainly reduces the risk for people who inject drugs. Okay. What are the clinical implications? Well, it's very useful for counselling. If you can tell people that you're no longer infectious, that's a huge weight off their shoulders. They can have sex with whoever they want. To a certain extent, women can have babies, not transmit the virus. Breastfeeding is still a little bit individualized because there is still a small risk with breastfeeding, but it is a very small risk. But certainly, mother-to-child transmission is done almost down to zero if the woman is undetectable, and sexual transmission is zero. So for reproductive planning, it's very important for both men and women, and the public health messaging that these individuals are no longer infectious sexually, and the risk of transmission is effectively zero. It is zero with these individuals whose virus is well suppressed. So long-term care, we aim for simplified regimens. There are some issues with drug interactions, not many drugs, some of the tuberculosis drugs, some of the also the I think not anti-epileptic drugs, anti-seizure medications. There's still some interactions, but in general, there's very few interactions with these drugs. And just by putting a person on one pill that's easy to take, it supports adherence. Many of us, especially as we're getting older, are already on medications for cholesterol or hypertension or depression or pain. And so adding one tablet in is actually a very easy thing to do. A little bit trickier for some young people who aren't on any medications to get them in the habit of taking treatment. And this is where pharmacists and peer support workers can be really helpful and invaluable in helping people to stay adherent to these medications. Aging with HIV has become a big issue in the last few years. Well over half the people with HIV in Australia are over the age of 50, and that's rapidly aging. And this is the same in Western countries around the world, quite different to Africa, parts of Asia, Latin America, where it's predominantly a young epidemic. In Australia, most of Europe, or certainly Western Europe, North America, it's predominantly now becoming an old person's condition. And there's a whole lot of interactions that are going on. There's cardiovascular disease, which seems more common in people with HIV. Bone and renal health can be impaired for various reasons. Neurocognitive and mental health issues are more prominent in people living with HIV. Frailty is more common. And people can age at a quicker rate. And there's various reasons for this. If people want to know about it, I can talk more about it. But there is more frailty in old people with HIV. And loneliness, this epidemic of loneliness that we're seeing, particularly in men as they age, is a real problem. Many people living with HIV lost a lot of their friends in the epidemic and may not have close relationships with their family. They came from a time when being gay was much less accepted than it is now, and having HIV was heavily stigmatized. So there's a lot of loneliness in some of this older population. For HIV prevention, we use combination prevention these days. I'll talk about that. Biomedicals, behavioral, and structural. So there's a lot of work has gone into HIV prevention over the decades. Treatment as prevention is a concept that came out probably around 20 years ago, particularly out of Canada, Vancouver. There was Julio Montane was the lead there, and he pushed this very heavily and pushed it around the world, that going on to treatment is actually a form of prevention because the person becomes undetectable. And what this also does, it really reduces the amount of virus within the community. So, again, I'm from Cairns, so I'll give you a Cairns analogy. If you're going to go and swim in a billabong, it's very safe as long as there's no crocodiles there. If there's crocodiles there, it's not so safe to swim in that billabong. And it's the same with HIV. If you're going to go playing in the playground and having sex, casual sex, and there's no HIV, you're very safe. If there's HIV, you're not so safe. So if people have got HIV infection and they're on treatment and they're undetectable, they're not going to transmit, then the amount of virus in that person's community is going to be reduced. And if their mates are all undetectable as well, and their cohort, it really means that the chance of anyone who's HIV negative contracting HIV there is much less. Whereas if people aren't on treatment, there's high levels of virus in that community, and transmission is really multiplicative. It's just, it's exponential. And this has a population level impact if you get as many people as possible into treatment. And that's one of the reasons we're seeing this drop in HIV infections in Australia. We have very good levels of treatment. Condoms, still very valuable. We kind of forget about condoms a bit, but they're also good for STI prevention. And it's really part of choice-based counselling for people who are HIV negative. They can go on PrEP, they can use condoms. HIV positive men can still use condoms. So they still have their place, but I think it's fair to say they are seen as sort of an older technology now. And of course, the technology hasn't improved for the last 80 years or so, which is quite different to everything else we're using. PrEP, we'll talk about HIV prevention now, PrEP. So this is pre-exposure prophylaxis. Something you do usually every day, but not necessarily. You take a tablet, and that prevents you acquiring HIV if you're HIV negative. You can take it daily, so you take a pill every day, or you can take it on demand. So if I'm going to go out and have fun tonight, I take 2 tablets now, have some fun, tablet tomorrow at this time, tablet the day after. So that's 2 tablets, 2 + 1 + 1, and that's all you need to take for that event. And that works very well if you're not having sex all the time, and if you know when you're going to have sex, because you have to leave at least 2 hours before your first dose and the sex. So that's on demand. About 1/3 of the guys with HIV in Australia take it on demand, and about 2/3 take it daily. They just take a pill every day, as a woman would take the oral contraceptive pill to prevent pregnancy. Highly effective, over 99% effective, very few failures if it's used properly. And Australia has probably the highest uptake of PrEP in the world. Our gay communities were really rapid adopters of this. Surprisingly so. When I was in Queensland, we were given, government gave us 50 places, 50 doses of this for people, and for the whole of Queensland. We weren't sure if we were going to be able to find 50 people who wanted this. We did. And then we started the QPrEP study, and we very rapidly had 3,000 enrolled. So, and New South Wales and Victoria had very good take up, as did South Australia. So, really quite amazing levels of take up in Australia for this technology. Who benefits? Predominantly gay men. So men having sex with men. They're the ones that really benefit from PrEP because they're at highest risk. Serodiscordant couples. So if I have HIV, my partner's negative, if I'm not on treatment, my partner can have HIV, and she or he will not contract HIV if they're taking PrEP. The other option is for me to go on treatment, and then I won't transmit. Some couples, they want what we call the seatbelt and airbag approach. So I'm on treatment, my partner's on PrEP. So we're sort of doubly protected. And that's an individual decision. Not really necessary, but some people prefer to do it, and there's no harm in that. And also people with recent STIs. So, the frequent flyers who are contracting chlamydia, gonorrhea, syphilis fairly regularly should certainly be considered for PrEP because they're at higher risk too. So in clinical practice, someone comes in wanting PrEP, we offer baseline testing, 3 monthly review, and then every 3 months. The government has agreed to extend that to 6 months supplies of the drug. They agreed in December. It's supposed to be happening soon, but we don't have a date yet. So at the moment, it's every 3 months someone comes back for their testing and a new script, but that's going to extend to 6 months, hopefully very soon. We check kidneys because the drug can affect kidneys, and we do STI monitoring as well. PrEP, this is post-exposure prophylaxis. So this is someone who's not on PrEP, HIV negative, they have sex last night, unprotected sex, and then today they go, oh, I better do something about that because I could be at risk. The idea is to start as soon as possible on your antiviral drug. It must be taken within 72 hours of exposure. It's not effective after that. So if you wait a week, it's too late, unfortunately. It's a 28-day course of medication and is highly effective at preventing HIV acquisition in those individuals. What we then try and do is transfer that person from PEP to PrEP. So they've had an event, we treat them for 28 days so they don't contract HIV, and then we keep them on those tablets if they wish, so that they are then protected in the future if they have unprotected sex. So it's PEP to PrEP, and that's a very common thing. So PEP exposures, sexual exposure, of course. Unprotected anal sex, occasionally vaginal sex, though the risk there is much lower, so we're less inclined to give PEP for that. ASHM, the Australasian Society for HIV, Viral Hepatitis and Sexual Health Medicine, quite a mouthful, ASHM, that's why we call it ASHM. ASHM has excellent guidelines, PEP guidelines, and excellent PrEP guidelines too. So if you point your web browser to ASHM, Google, ASHM PEP or ASHM PrEP, you'll come up with the guidelines and how to give PEP and who should have PEP, all spelled out very well. Occupational exposure, particularly for healthcare workers who've sustained a needle stick injury, for example, it can also be given. And in sexual assault cases, though not routinely, and there is a bit of controversy about that, the HIV doctors, public health people in general don't recommend it for most sexual assaults if the sexual assault is a female being assaulted by a male. But there are some situations where you would do it, especially if it's a higher risk individual. Male sexual assault, more likely to use it, obviously, if there's been anal sex involved with another male. But in general, it's not recommended, but a lot of the sexual assault doctors are more inclined to use it. So there's a little bit of tension between that. So sometimes the person will end up with it and sometimes they won't. That varies a bit around the country. STIs and HIV, they're linked. People who get HIV get STIs and vice versa. The more often you play in the playground, the more risk there is. There's behavioral links, there's biologic links. So STIs cause inflammation, they cause pus cells to be around. HIV can get in through those pus cells, through those immune cells, and also through breaks in the skin caused by STIs. STIs can increase the HIV viral load if someone's not on treatment, particularly syphilis can increase the viral load. So they kind of work hand in hand together to assist each other. And so regular screening, if someone has an STI screen, we check for HIV. If someone is coming in for their regular HIV review and they're sexually active, we test for STIs. So we work together to try and reduce rates of both. I think the biggest issue that people with HIV still face is stigma and discrimination. And I was the head of the HIV Foundation in Queensland for several years, over 10 years ago. And we did a big campaign, big media campaign in Queensland aimed at the general population, trying to reduce stigma levels about HIV, and pretty much failed dismally. We increased awareness, we increased knowledge, people felt more comfortable about understanding HIV. Stigma levels hardly dropped at all, even with huge multimedia campaigns. So very hard to reduce that stigma level. It impacts testing and retention in care. People feel shame, they feel guilt about HIV, or they're very worried they'll be diagnosed with HIV and the consequences of that for themselves, their family, their friends, their lovers. So this stigma is huge. Big role for us as clinicians to normalize HIV, and particularly using the U equals U, undetectable equals untransmissible, that once the person's on treatment, they're no longer infectious. And trying to reduce the awful stigma that people with HIV can feel. Nurses, for those of you out there, testing, HIV testing, triaging, education of patients and communities, and adherence support for those living with HIV to assist people and better quality of life, and really a multidisciplinary team setting, which is often what we use for HIV. So big role for nursing. Nursing in HIV has just been a huge part of the whole epidemic since the beginning. Allied health, particularly mental health, social and structural support, incredibly important. People with HIV have worse rates of mental health, worse mental health outcomes. So a lot of work can be involved here. Drug and alcohol issues are present as well. Issues around reproduction, education. So a big role for allied health too. Public health and clinical health are very closely integrated with HIV, similar to tuberculosis, for example. You really need good treatment of a person with HIV, and that helps the public health response. And the public health response in finding HIV, media campaigns to reduce stigma and discrimination, help with clinical care. So both of them work hand in hand. So the take-home messages are that HIV is a chronic, manageable condition, prevention, highly effective, and clinicians are really central to ending HIV in Australia. So that's it. There's my email. If you have any questions or want to email me, feel free to contact me. And yeah, I wish you all luck with this. Do read a bit about HIV, find out a bit, talk to people about HIV. You might know someone living with HIV, and if they're comfortable, have a chat with them about what it means to them now. You might know gay guys, for example, involved with PrEP, taking PrEP. And again, if it's not too personal, you might be able to talk to them about what it means to them. It's quite a different world now, the HIV world, than it was when I started this, when everyone died and the fear and the stigma were huge. We've come a long way, still got a fair way to go. So I'll hand back to Kate. Thanks.
Thank you, Darren. That was absolutely fabulous. Thank you so much for that. I'm just going to let you know, Darren, you're still sharing your screen. Oh, and there's a dog. Oh my gosh, we're getting it all today. Um,
Okay, how am I going to unshare that?
yeah.
Oh, there we go. Sorry.
No, don't apologize at all. Like we said, we're experts at Zoom until we need to use it. Uh,
Exactly.
but thank you so much, Darren. That is absolutely fabulous. Does anyone have any questions? I'm going to give people a minute or two to think in case they do and type it out. But Darren, I do have a question out of curiosity. You said now with art, there's a lot of long-acting injectables out there, and I was wondering, with your patients, are you seeing an increase in uptake with injectables, or is it still mainly the medication?
That's a really good question. And the the main drug company that was involved in rolling out the first of these medications asked me and all the other HIV doctors around Australia before they launched their product, how many people are going to take it up? And we had no idea. And it's fair to say the uptake has not been nearly as good as the drug company hoped.
Okay.
Um, it varies a bit. Perth, it's gone gangbusters over there. It's very popular. There seem to be individual clinics where there's been big uptake, but in general, it's probably been a bit disappointing. We thought there'd be a lot more interest, and there are certainly some people taking it, but in my practice in Cairns, we had 500 or 600 people living with HIV, and only a handful took it up. So it was kind of disappointing.
Interesting. Do you think it's going to be similar with these new forms that they're going to bring out?
We think it might be better. These are 2 monthly injections. It's inconvenient. You think even Depo-Provera, the contraceptive, is every 3 months. Implanon is every 3 years. We think 2 months is probably just too much, and they're painful injections. This lenacapavir at 6 months, we think uptake for 6 monthly and 12 monthly will probably be much better when it arrives.
Perfect. Thank you, Darren. Lindy, I see you have your hand raised.
Hi, yeah, thanks. Thanks for the fantastic presentation, Darren. I really appreciated you breaking it down into like lay language, which so I'm a researcher looking at sexual and reproductive health and the Pacific Australia Labour Mobility Scheme. I'm interested to know if we have any like national data around people living with HIV in Australia who are overseas born and which countries they've come from, and particularly wondering if you know if sort of the HIV outbreaks in PNG and Fiji, if we're seeing that coming to Australia.
Yeah, really good question. The Kirby Institute, if you go and have a look at their data, they have all of this broken down in wonderful graphs that you can upload. So Kirby, Kirby, at the University of New South Wales, has all this epidemiological data. But yes, what we're seeing, as I said, is we're seeing this drop off in people born in Australia acquiring HIV and this rise in people born overseas. And they either are acquiring it overseas, especially when they go back home for periods of time, back to visit family, or might have, um, you know, various work or other things. They're acquiring it there, or acquiring it in Australia, often from other overseas born people. So the countries in particular are Asia, so it's Thailand, Philippines, China to a lesser extent. In Cairns, where I was, and probably in Darwin, certainly Papua New Guinea. And we were, by the time I left Cairns, I think maybe two-thirds of our new diagnoses, or it was one half to two-thirds, were associated with Papua New Guinea in some way. So either white fellas from Australia going over there and working and acquiring it, or people from PNG coming to Australia with HIV. So they were the main countries. I think we're starting to see a little blip from Fiji, small numbers, but occasional individuals from Fiji or diagnoses associated with Fiji, and a little bit from Latin America, South Africa, but yeah, Brazil in particular, because quite a lot of young people from Brazil over here. But mostly Thailand, Philippines were two main countries, and I think China might have been third.
Great, thank you.
Fabulous. Does anyone else have any other questions? If not, I'm going to end it there. Again, massive thank you, Darren. That was fabulous. And thank you, everyone, for taking time out of your day to join Search. We will be back for another Sexual Wellness PD in April, nearly said March, getting my months wrong, with Hilary Caldwell. So please sign up to that. That will be another great session. Thank you, everyone.